Welcome to the workshop, New Cancers After Transplant, Steps You Can Take to Reduce Your Risk. My name is Michaela O'Brien, and I will be your moderator for this workshop. Before we begin, I would like to thank the William G. Pomeroy Foundation, whose support helped make this workshop possible. It's my pleasure to introduce today's speaker, Dr. Saro Armenian. Dr. Armenian is the director of the Center of Survivorship Outcomes at the City of Hope Cancer Center in Duarte, California, and past president of the Children's Oncology Group's Survivorship and Outcomes Committee. He is an internationally recognized physician scientist focused on improving the health outcomes of childhood and adult onset cancer patients. Please join me in welcoming Dr. Armenian.
Good morning and good afternoon to many of you on the East Coast. Just want to say it's such a thrill and an honor to be here as part of this symposium. Hope you can hear me okay. I'm going to talk mostly today on second cancers after transplantation, both allogeneic and autologous transplant, with a large focus on preventive strategies and proactive strategies for steps you can take to reduce your risk. So hopefully by the end of this workshop, you will be able to understand the potential secondary cancers that can occur after allogeneic as well as autologous transplant, understand the incidence and risk of developing second cancer after transplant, and then the medical tests and exams that are needed, the timing as well as the strategy to reduce the risk, and then lifestyle modifications that can be facilitating these strategies. So let's talk about, in general, the concept of cancer development in the general population outside of transplant. And, you know, there are some well-established risk factors, so genetic predisposition for developing a cancer, and this could be a family history, or specific syndromes that individuals are born with, typically seen in childhood, such as issues with telomere shortening that predispose someone for developing a cancer earlier than you would expect for the general population. Normal aging itself clearly is the biggest risk factor of developing a cancer, and then additional well-established carcinogens such as smoking, alcohol, excessive alcohol use, prolonged sun exposure, in particular frequent sunburns, and as well as specific viruses such as HPV and EBV have been associated with cancers, which I'll talk about a little bit later. But we also know that cancer treatments themselves and the specific exposures such as chemotherapy, radiation, prolonged immunosuppression can increase the risk of cancers, as well as immune deficiency syndromes and disorders that individuals are born with. So that's sort of the big umbrella, broad categories of factors that drive cancer risk. So let's dive in a little bit more and talk about the specific risk factors for cancer after the transplant. So these include graft versus host disease, both acute as well as chronic, medications used to treat or even prevent graft versus host disease, underlying diseases and associated prior treatments, so some cancer treatments or myelodysplastic management myelodysplastic disease itself can result in subsequent cancers, and then transplant-related chemotherapy and radiation. We also have a risk associated with, based on donor, so own versus other stem cells, which I'll talk about, maintenance therapies associated with transplant, and then new lifestyle risk factors that develop after transplant as a result of the therapies, and how they drive transplant risk factors, which I'll talk about. So that's a broad category. So let's talk very briefly. I'll start with some case examples, first focusing on patients who underwent allogeneic transplant. And why does it matter to talk about subsequent cancers in this population? So you have a 47-year-old male with a history of acute lymphoblastic leukemia, otherwise known as ALL, who underwent a matched unrelated bone marrow transplant, who is now a 3-year survivor. He presents to the survivorship clinic with a 2-month history of a skin lesion on his forehead. And a biopsy was performed after referral to dermatology, and this patient ended up having a skin cancer, specifically squamous cell carcinoma. So what are the specific risk factors and relevant history for this particular patient. While the patient had male pattern baldness, the hair itself obviously protects from sun exposure, and that's commonplace. The forehead is a common place for these cancers to develop. He was non-Hispanic white, and so the more fair-skinned you are, the higher the risk of skin cancer, as it would be for the general population. He was a construction worker, so spent a lot of time outdoors. Again, another risk factor for skin cancer in the general population. But then generally speaking, when you talk about transplant-related additional risk factors, he had received total body irradiation, which puts you at risk for skin cancer because radiation is a risk factor for skin cancer. And then he also developed graft versus host disease, which in and of itself, both for the skin graft versus host disease as well as the management of the graft versus host disease, in his case was CellCept for more than 3 months, so prolonged immunosuppression. All of the combination of all of these risk factors likely contributed to the development of skin cancer in this patient. So what do we know about new cancers after allogeneic transplant? And I'll talk about autologous transplant later. So in general, the risk is twice that would be expected for the general population. So it's important to contextualize this because cancer is an aging disease. So you always want to evaluate it in the context of relative to the general population. So it's about 2 times the risk compared to the relative population. And in fact, with longer follow-up, and as our survivors get older, that general risk relative to the population increases with time. So the highest relative risk is for skin as well as oral cancers, bone and soft tissue cancers, as well as liver tumors. Specific to solid tumors, there's a higher risk of lung, breast, prostate, colorectal, as well as melanoma. And essentially what we're seeing is what we call a left shift, so earlier onset various cancers that you would expect in the aging population, but you're seeing it earlier and a higher risk in our allogeneic transplant population. What are the patient and transplant-specific risk factors? Obviously, older age, as we discussed earlier, but then graft versus host disease and associated radiation exposure are the biggest drivers in this population. Let's talk about a unique condition that we see often after allogeneic transplant, which is lymphoproliferative disorder. So this typically presents in the first 2 years after transplant, and it's associated with activation of Epstein-Barr virus, or EBV, which many of us harbor, but is essentially dormant. Once someone is chronically immunosuppressed, that virus essentially emerges, and it presents with lymphoma-type clinical characteristics such as big enlarged lymph nodes and fevers, weight loss, etc. So what's interesting, in fact, is that because this is a dormant virus in all of us, the more, and it's typically kept at check based on your immune system, the more the immune system is suppressed after the transplant, the higher the risk of this EBV being activated and this lymphoproliferative disorder developing. So patients who undergo T-cell depleted transplant, where their T-cells are not there as part of the graft, severe graft versus host disease, or cord blood stem cell source. These are all risk factors for individuals to develop lymphoproliferative disorders. And the treatment is relatively straightforward. Oftentimes they're responsive to Rituxan, which is an antibody-based therapy typically used for lymphoma, as well as in some cases chemotherapy. So let's talk about another patient scenario, which is patients who underwent autologous transplant. So this is a 32-year-old female with a history of Hodgkin lymphoma, diagnosed at 17 years of age. So nearly 15 years after their diagnosis, they were treated with 6 cycles of ABVD, as well as chest radiation therapy because they had high-risk disease. She eventually relapsed and underwent autologous stem cell transplant as a rescue, and she was cured of her Hodgkin lymphoma and is now a 15-year survivor. She feels a suspicious breast mass and presents to her physician for workup. And eventually, a referral was made and a biopsy was made, as well as imaging studies, and she's diagnosed with breast cancer at age 32. So let's talk about what are the relevant risk factors and what's the relevant history for this patient. Interestingly, when you think about breast cancer developing in a 32-year-old female, you think about family history and genetics, but this patient had no family history of breast cancer, and her genetic workup was negative. But she did have a 10-pack year smoking history, which is a risk factor. And the original site of disease, as you may recall, was the chest or the mediastinum, where she received 20 gray of involved nodal chest radiation therapy. And in this case, it's panel B. And what you'll see is that she received radiation to the mediastinum to control the lymphoma, but that also likely included the breast tissue. And radiation to the breast tissue is the biggest risk factor for developing breast cancer after treatment of lymphoma. She received conditioning chemotherapy with Beam, which is a combination of drugs that is typically not associated with breast cancer. So based on this patient's history, it's really the 10-pack year history of smoking as well as the breast radiation that she received or the breast radiation that she received that likely had the breast tissue in the radiation field that put her at greatest risk. So what do we know about new cancers after autologous transplant as general risk factors? So obviously, just like allogeneic transplant, older age at both transplant as well as older acquired age put you at higher risk of developing new cancers. It's important to understand what the type of cancer that somebody had as well as the associated therapy, because some treatments that were provided with the initial cancer put you at high risk, and the classic example was the radiation for Hodgkin lymphoma and risk of subsequent breast cancer. Post-transplant therapies, including some maintenance therapies that are given for myeloma, which I'll talk about in a minute, may put someone at higher risk of cancers, and then radiation therapy, which I talked about, either for control of the underlying disease, which I mentioned for lymphoma, or is used as part of conditioning, which is less often for autologous transplant than it is for allogeneic transplant. So I'll briefly touch on myeloma, which is the reason why I'm going to focus on that is because it's the most common indication at this point for autologous stem cell transplantation in the United States or even worldwide. There's overall no increase in second cancers in myeloma patients who had a transplant compared to those who did not have a transplant, which is reassuring. There's a 50% increased risk of leukemia lymphoma diagnoses compared to the general population, so it's a very small subset. But the interesting thing is that new cancers that develop after myeloma typically do not impact overall mortality risk. There's a little bit of a caveat here, and the fact is that the myeloma is very difficult to completely cure. In fact, what autologous transplant does for many of the individuals is that it essentially provides them prolonged periods of myeloma-free survival. So sometimes, it's difficult to assess the impact of second cancers in this population when they may potentially succumb to the myeloma itself. And there's some emerging concerns or signals around Revlimid maintenance therapy that is beginning to be explored in our group. Another relatively rare entity that can definitely happen after autologous transplant is myelodysplastic syndrome and acute myeloid leukemia. So as I mentioned, many people are undergoing autologous stem cell transplant for myeloma, but also for lymphomas. And for these individuals, a certain small subset will develop myelodysplastic syndrome, which means abnormal bone marrow, as well as progression to acute myeloid leukemia. And that may be due to both marrow injury, so bone marrow injury from prior cancer therapy, so even before the transplant, which increases after autologous transplant because they receive chemotherapy for the transplant. And it's typically associated with alkylator chemotherapy exposure, such as Cytoxan and ifosfamide, both as part of conditioning or pre-transplant topoisomerase inhibitors, such as etoposide, as well as radiation exposure. MDS, myelodysplastic syndrome, or AML, typically develop in the first 5 years after the transplant, and outcomes are generally poor unless additional more aggressive therapies are implemented, such as another allogeneic transplant. So for patients who develop MDS AML, after auto transplant, typically the curative approach is to try to get to an allo transplant. So what are the big factors in terms of outcomes after second cancers, and what are the factors that impact outcomes? So a lot of it depends on the type of cancer that they develop. So skin cancer outcomes are very different than pancreatic cancer outcomes. The age of the patient and the stage at the time of diagnosis, and then the extent of localization. These are risk factors that we would typically expect are similar to what for the general population as well. It also depends on the effectiveness of the drugs that you have at your disposal. And then the chronic health conditions. So many of our transplant patients have a number of comorbidities or chronic health conditions that develop after the transplant, and that may impact their ability to receive additional therapy for the treatment of their second cancers, whether it is poor general health, poor organ function, or ongoing graft versus host disease and associated immunocompromised status that may prevent them from receiving additional immunosuppressive therapies. There was a paper that looked at outcomes for solid tumors after transplantation, and generally what they were able to do is categorize the various cancers that they saw in a large population-based study into favorable, intermediate, as well as poor. There are no big surprises here. The ones that are favorable for the general population are also favorable for our transplant population. These include thyroid cancer, cervical cancer, prostate, breast, as well as melanoma. And then the intermediate risk, and then you have the poor cancer categories, poor outcome cancer categories, including pancreas, gastric, brain, which again generally have poor outcome for the general population. When you look at these incidences of mortality, so risk of death due to a second cancer, either breast, colorectal, or lung cancer after transplant, what you'll see is that while breast is more likely to occur in this population, the overall mortality associated with it is much less than a rarer cancer such as lung cancer, which has a higher mortality. So let's get to the meat of the talk, which is what can survivors do to reduce their risk of new cancers after transplant? So ultimately, the goal is that these individuals are survivors and they had to undergo stem cell transplant because that was really the only curative approach for them. And the goal is ultimately to reduce the factors that increase risk after transplantation, because we know that the big hits that they receive are the treatments and the transplant and the pre-transplant exposure. So you really want to minimize the second hit or the third hit risk factors that put you at risk for cancers. And this would include lifestyle modification, which I'll talk about a bit, exercise, no smoking, low alcohol intake. The other additional approach, so one is to avoid risk factors, and the other is to perform aggressive screening and close follow-up if you have these risk factors, whether they're treatment-related or otherwise. It's important to follow established guidelines for wellness and increase surveillance that is personalized to the specific therapies that you receive that put you at higher risk. And early detection is key to optimize outcomes associated with that diagnosis. So general key sort of takeaway messages about overall steps to prevent cancer. And I would argue that these are applicable to the broader population, and I'll get to more specific recommendations for our transplant patients. So no tobacco use, skin protection from UV and sun exposure, maintain a healthy diet, keep a healthy weight and stay physically active, avoid risky behaviors, including excessive alcohol intake, make sure that you're getting appropriate immunizations based on your age and recommendations. So if you're early in life, HPV vaccination is critical for prevention of cervical cancer or penile cancer in males, and then hepatitis vaccines is very important to get revaccinated, especially after allogeneic transplant if you have not done so. Empower yourself with your own and family history. It's important to understand, again, we're talking about multiple hits to your own biology that drive risk. So if you have a family history combined with therapeutic exposures that put you at risk, plus the transplant, you can imagine that those are issues that you need to be aware of. So what are the signs and symptoms that could be concerning? So any new lumps or bumps that you feel should be brought to your primary attending doctor. Unusual fatigue, fevers and sweats, prolonged sweats and night drenching sweats. Persistent cough, hoarseness, and chest pain that is unexplained, so not associated with a virus or a flu. Easy bleeding or bruising that's unexplainable. Abdominal pain, loss of appetite, and difficulty swallowing that typically persists for several weeks. New unexplained blood clots, sores, and skin infections, which may be suggestive of immunocompromised status, as well as change in neurologic status, which would be really concerning for CNS or brain cancers. So I'm going to talk now specifically about individual cancers and steps you can take to prevent these types of cancers after transplantation. So skin cancer, it's one of the most common post-transplant cancers. It's much more common in patients who underwent allogeneic versus autologous transplant. And prevention is key. Sun avoidance or high SPF sunscreen is integral. It's important to have regular dermatologic visits to perform full body examinations. So we recommend at least once a year dermatology visits for patients who underwent allogeneic transplantation. And early detection is especially important to optimize outcomes. And then compared to skin cancers in non-transplant populations, skin cancers in patients who are in transplant survivors tend to be more aggressive. So it's very important to be engaged in aggressive screening and early detection. And it's important to be aware of suspicious lesions. So what do these suspicious lesions look like? And I'm going to break it down across melanoma, which is the most feared skin cancer, squamous cell carcinoma, as well as basal cell carcinoma. So melanoma, what are sort of some of the hallmarks of melanoma that you should be worried about? And we look at them as the A, B, C, D, E's of melanoma detection. On the top, we have normal. On the bottom, we have what a melanoma would look like. So asymmetry is key. Borders are uneven typically. There are multiple colors as opposed to a single color within a lesion. They're typically larger than a quarter inch. And importantly, they're often changing in size, shape, and color. So these are sort of the hallmarks of what you should be aware of for melanoma risk. Squamous cell carcinomas are a little bit difficult to pick up, but typically they have this rough texture, this keratotic texture. While they are slowly growing, they can sometimes grow over weeks, and they have this weird shape look that essentially looks like what I showed earlier with that patient, and this kind of like the scab-like look that just typically is not going to go away and heal. Basal cell carcinomas are, again, difficult to pick up. A lot of times they're associated with sun exposure, so they're going to be in places where there is a lot of sun exposure, including the ear, the nose, the forehead, as well as the top of the head for males who have male pattern baldness. So I would be worried if there was unexplained whitish scar area, there was a shiny bump, or there was a nodule or reddish patch or an irradiated area that is in an area of the patient where the patient may have received radiation. If they have persistent non-healing sores, that's really a red flag. And then pink growth with slightly elevated rolled borders with crusted indentation in the center. That, again, is another sort of suspicious lesion that you would worry about for basal cell carcinoma. Basal cell carcinomas are typically non-life-threatening. They can be excised in clinic as an outpatient procedure, but melanoma, on the other hand, is quite worrisome, so you should be aware. So how does one check for skin cancer? And these are the general guidelines that we have recommended from our colleagues. So step one, gather a hand mirror, a hair dryer, and two chairs or stools, and a partner and a close friend that you feel comfortable having to facilitate a full skin examination. Stand in front of a full-length mirror, look at your whole face, including your nose, lips, mouth, ears, behind your ears, and use a hand mirror, ask your partner to help you see. If you have a lot of hair, use a hair dryer by layer to check your scalp in the mirror, or use the hair dryer to move your hair aside. Check your hands, start with your palms, back of your hands, look between your fingers and then under your fingernails. Take your shirt off and continue to look at your wrists and look at the front and back of your forearms. Stand in the front of the full-length mirror, bend your elbow and check your upper arm and armpit, and check the other side. For those of you who think I'm going too fast, no worries. You can download these slides and they're very available for you. Finish undressing and check your neck, chest, and front and upper body, including your stomach. Women should lift their breasts to see if under the skin folds to see if there's any suspicious lesions there. Use the hand mirror with the help of your partner to check your back. That's an area that's often missed, and a lot of exposure happens there, including total body radiation as well as sun exposure. Continue to use your hand mirror to look at your buttocks, back, as well as the back of your legs. And then lastly, sit down and prop your leg up on a stool to examine groin area with a hand mirror. Check the front and sides of both legs, both feet, between your toes and toenails and heels, and the soles of your feet. Now, this seems like a lot, but it really takes a few minutes to do all of this, and it doesn't need to happen every day. Once every few months or so is more than reasonable. Plus, a dermatologist should be helping you facilitate the screening annually at least. So oral cancers. So typically oral cancers happen after allogeneic transplant. They are associated with a history of graft versus host disease, and it's imperative that you're having regular dental visits for comprehensive screening. So it's not just about your teeth when you visit the dentist, but it's also for the gums and tongue and below the tongue, so that if there's any suspicious lesions, they're picked up. There should be a low threshold for consultation with an oral surgeon if there are suspicious lesions, and I've shown two. One on the bottom is a very excessive case of an oral cancer after allogeneic transplant, and one on the left at the top is actually one that probably would not have been picked up unless they went to the dentist. So incredibly important is a history of graft versus host disease, especially skin, oral graft versus host disease, that you are making sure that your primary care providers are aware of these suspicious lesions. So what about breast cancer? We talked about this already a bit, but I'll just reiterate some of the key things that you could do to prevent and be more proactive. So what are the risk factors? Prior chest radiation therapies that we discussed with that female in that case study, but also total body irradiation as part of allogeneic transplant. It's recommended that individuals undergo annual breast examinations starting at 25 years of age or 8 years after radiation therapy or total body radiation, whichever comes first, no later than age 40. Again, for patients who receive radiation, whether it's TBI or chest radiation, females obviously, we recommend regular annual breast exams starting at age 25 years of age, as well as mammogram, as well as breast MRI that are alternating every 6 months. That is essentially the guidelines that are for individuals who have genetic predispositions, like the BRCA mutations, like the Angelina Jolies of this world. So it's really important that, we are following the more aggressive guidelines for the general population. If you're at average risk, so you have not received the radiation exposures, then typically between 20 to 40 years of age, you follow regular guidelines, which is clinical breast exam every 1 to 3 years, and an annual exam and mammogram after 40 years of age. For cervical cancer, so the biggest risk for cervical cancer in the general population and in the transplant population is HPV, human papillomavirus. So it's important if early in life that you receive the HPV vaccine for prevention of cervical cancer and penile cancer in males. In younger individuals, important to undergo regular pelvic examinations with cervical smears and an annual Pap test and HPV DNA test, as would be recommended for all transplant patients. Well, for liver cancer, thankfully it's relatively rare. In the past, one of the highest risk factors was blood transfusions, but now with better screenings, those risk factors are much, much less. But nonetheless, we can vaccinate for many of these. So for example, for hepatitis B, it's important to vaccinate and then to treat. So post-transplant, you can check titers and evaluate things, but most patients will have to have post-allo transplant their hepatitis B series repeated. Hepatitis C, there's no vaccination, you just treat. It's important to limit your alcohol intake. And then cirrhosis in and of itself is a risk factor for liver cancer, not due to alcohol intake, but due to chemotherapy, graft versus host disease, where they can have substantial liver injury and damage in some individuals, obviously not everybody. And then iron overload associated with repeated blood transfusions could contribute to liver injury and ultimately, if severe enough, to liver cancer. It's really important to identify abnormalities and blood markers of liver injuries, such as liver enzymes elevations, because if it's gone too far, then it's really difficult to treat. Turning our attention to colorectal cancer, it's one of those cancers that clearly early colonoscopy has dramatically improved outcomes for the general population. So it's really curable if picked up at an early stage with surgery alone. So what are the transplant and cancer-specific risk factors for colorectal cancer? So GI, graft versus host disease, puts individuals at higher risk of colorectal cancer, as well as radiation to the abdomen puts individuals at higher risk of colorectal cancer. So what are the tests? Colonoscopy, sigmoidoscopy, as well as stool, blood, and DNA testing. It's recommended that the first colonoscopy should be performed at 45 years of age, and individuals should be screened up to 75 years of age. There may need to be more frequent or even earlier screening if individuals are at higher risk. So if there's a genetic family history, or in pediatric patients who are now adult survivors treated with abdominal radiation therapy when they were children for their primary cancer, and that typically is for individuals such as Wilms tumor, neuroblastoma, who then go on to undergo autologous transplantation. And then finally, as far as cancers are concerned, lung cancer. So again, it's a relatively rare cancer after stem cell transplantation, and clearly the biggest driver of risk is smoking. But as I mentioned, it's a multiple hit issue. So the first hit per se is smoking, but if that individual who has an extensive smoking history then receive radiation, whether it's TBI or chest radiation for the treatment of liver lymphoma, the combination of the two puts you at higher risk of developing lung cancer compared to the general population. So what can we do to screen for early detection? So clearly screening with low-dose CT of the chest. Low-dose CT is very important because you want to minimize the amount of additional radiation exposure associated with the CT scanning. So low-dose CT scan of the chest is recommended for the following high-risk groups. So more than 55 years old and more than 30 pack year smoking history, or more than 50 years old and more than 20-year pack year history with another risk factor, such as radiation exposure. So for our transplant patients who receive TBI, have a smoking history, or receive chest radiation exposure, the screening starts earlier, and there's a lower threshold based on pack year history. I've just touched the tip of the iceberg. There are clearly many sources and resources that are at your disposal to provide you more information about cancer screening and cancer prevention and detection, whether it's through the BMT Infonet, American Cancer Society, ASCO guidelines, or the Cancer Network that's available, as well as the Leukemia and Lymphoma Society. There are many patient-friendly and accessible resources that are readily available, but hopefully this has just given you sort of a broad overview of what are the areas to be worried about or be concerned about. Ultimately, what do we encourage our survivors to do? It's really important to learn about the treatments you received. As I mentioned, many of the factors that I mentioned were specific risk factors associated with either the transplant or the primary cancer. So the more you are informed about those, the more you are armed with that information, the better you can help guide your primary care provider, where you may be a minority in that primary care provider's practice for differential screening compared to the general population. It's important to get regular checkups focusing on health risks related to your cancer treatment. Work with your healthcare providers to develop a long-term follow-up plan, both in terms of your primary transplant doctor as well as your primary care physician, and make sure that they are personalized to the therapies that you received and your unique risk factors. Ultimately, it's important to make healthy choices because clearly the choices you make after transplant could have an impact on long-term cancer and other health risks as well too. Ultimately, we believe, both at City of Hope and in the broader transplant community, that you are the most important member of the healthcare team. So the more proactive you are, the more informed you are, the better you will live your lives in complete health moving forward. So I'm going to stop there, and I'm happy to take questions from the audience, and thank you very much for your attention. And if you would like to reach me, you can reach me at sarmenian@coh.org, which is at City of Hope.
Thank you, Dr. Armenian, for this excellent presentation. We will now begin the Q&A session of this presentation. If you do have a question for Dr. Armenian, please use the chat box on the lower left side of your screen, and you can type in a question. We will answer as many questions as possible. Let's see, our first question is, does GVHD itself leave you more open to secondary cancers, or is it the steroid treatment that's causing the higher risk?
It's a great question. So it's actually the GVHD itself that is the biggest driver, because there's a lot of cell proliferation that happens as part of the GVHD. So whether it's GI, so colorectal cancer risk, skin, oral mucous membranes, those are the common areas that we worry about. The treatment of GVHD does increase the risk of certain cancers. So prolonged immunosuppression plus GVHD puts you at higher risk of skin cancer. But typically the GVHD itself the GVHD alone, irrespective of the immunosuppressive therapy, increases the risk. So, and also the longer the GVHD course, the more severe it is, the more chronic it is, the higher the risk.
Thank you. Is there any data on the importance of family history of the donor stem cells, or is that only pertinent for blood cancers?
That's a great question. Unfortunately, so you have two sets of donors. You have family, and then you have you sort of, you match sibling or, haploidentical, et cetera. These are all family members where you know the history. And then you have match unrelated donors, and typically we know very little about the unrelated donor's family history. For a variety of reasons, there's a lot of anonymity around the transplant, around the donation process. So I don't think anyone's really studied that, or if they have, I can't imagine that they've done it accurately because much of that information is not accessible. But I would say that while the some of the risk factors could be transmitted to blood. So theoretically, the risk factors for leukemia, lymphoma, and myeloma, those may be transmitted through the host. But there are additional tissue risk factors, such as breast, colorectal, or liver, et cetera. Those are really, I would be very surprised if those risk factors would transmit from the donor. I think those are inherently the genes and the DNA that you're essentially born with. So because it's typically, at the organ tissue level, it's difficult to replace the full DNA profile, whereas in the blood, it's not.
Okay, this patient wants to know they've had 44 infusions of Rituxan between 2007 and 2014 prior to an allo transplant in 2014. At what point will the secondary cancer risk diminish for me?
So I would say that the Rituxan in itself, there isn't a lot of data for long-term cancers. It's something that we're watching. I would say that the second cancer risk really depends on the specific exposures and treatments associated with that allogeneic transplant. So if they received total body irradiation, if they had prolonged, graft versus host disease, those are all risk factors that continue through the end of life. I mean, that's just something that's not going to go away. But like I said, the other types of cancers like myelodysplastic syndrome, AML, that we would see as a second cancer or a second marrow disorder, those are typically in the first 5 years. So it really depends. For solid tumors like skin, colorectal, breast, et cetera, those risks continue through end of life. But for the blood cancers like AML, acute myeloid leukemia, as well as marrow disorders like MDS, typically that's in the first 5 years after a transplant.
Can you comment on donor-derived leukemia etiology and treatment using any donor stem cell source?
Yeah, so that's again, I can't really speak too much about the treatment because the treatment, from my understanding, is not very different if it's donor-derived versus de novo, something that emerges out of nowhere. There's definitely this entity called donor-derived leukemias that we are aware of. It's very, very rare. So I would say that it's an emerging area of interest. We're looking at specific genetic markers that may put you at risk that may indicate sort of this leukemic potential in the donor stem cells, which we can screen for. But these are all early studies. And so from my understanding, at this point, there really isn't too much of a difference in terms of the treatment strategies for donor-derived leukemia versus the leukemia that derives outside the donor.
Can you comment on some concerns of Revlimid?
Yeah, as I alluded to, we started using Revlimid as maintenance therapy relatively recently. So, in order for you to consistently be able to get a long-term signal on Revlimid, on any kind of cancer, you really need a lot of data for it. And so what I would say is that there's an indication that there's a higher risk of leukemia, lymphoma in patients who receive Revlimid maintenance therapy. But as I mentioned, so A, the data is still early, so we need to follow it with time. And then B, for whatever reason, patients don't die of these leukemias and lymphomas. Typically, the cause of death, if they were, the cause of death is typically the myeloma itself. So in a way, there's kind of a bit of a silver lining there, that they're not necessarily as lethal. But I think there's much work to be done in this area.
This is a question on breast cancer. The patient wants to know if they have a 3D mammogram, do they need to do an MRI as well with no bloodline family history of breast cancer?
Yeah, so depends on the age, to be honest with you. We generally prefer MRI. So there hasn't been a lot of really good head-to-head comparisons of breast MRI versus 3D mammography in in cancer survivors and young cancer survivors. So I think generally speaking, there's a sense that 3D mammography is really good at detecting breast cancer in patients with dense tissue. But I would say that the gold standard, as far as I'm aware, is still going to be MRI, especially for younger individuals, because of the density of the breast tissue that may not be fully picked up by the 3D or the 2D mammography. So, but again, 3D mammography is still a relatively new area that's being explored. We have colleagues that are doing these head-to-head comparisons, so I would say we'll have more data probably in the next couple of years or so to help guide the guideline recommendations. But for now, the guidelines say standard mammography plus MRI alternating every 6 months.
Can you comment on the safety and efficacy of IVIG infusions?
I'm not aware of any data of IVIG in and of itself causing, risk of subsequent cancers. There are people who've received it for many, many years for a variety of conditions that are not related to cancer, like immunodeficiencies, et cetera, that people are born with. That said, I haven't done a recent extensive literature review on IVIG, so I'm just going based on, I haven't come across anything. That's not to say that there isn't any data there, but I haven't, I haven't come across it. It's not sort of a big signal that we worry about.
Okay. How about any correlation between VOD, SOS, and liver cancer?
Yeah, there's definitely a signal there. And I would say that it really depends on the health of the liver after someone has gone through VOD, SOS. So some people go through VOD, SOS at a relatively young age, short period of time, and then the liver health is quite normal afterwards and they're doing just fine. And others have, if they have prolonged course of VOD, SOS, and there's sort of irreversible fibrosis and even maybe some early signs of cirrhosis, clearly that's your biggest risk factor for developing liver cancer. But liver cancers are relatively rare. And with the incidence of VOD and SOS declining through better management and early detection, I think is probably not as much of an issue as it probably was, 10, 20 years ago or so. But routine monitoring for liver enzymes and liver function, the primary care provider or with your oncologist or survivorship doctor is very important, especially if you have a extensive history of VOD or SOS.
Okay. The survivor is 63 years old and 15 months post-transplant for MDS. What are some new cancers that I might watch for? I've had polyps removed 4 years ago. Any suggestions?
It would be tough for me to if it's only MDS. I'm assuming that the transplant itself was reduced intensity conditioning that did not involve total body radiation. So I think that, and I'm also assuming that there wasn't any significant GVHD. So all those things assumed, I think the risk of subsequent cancers is probably very low. But like I said, if total body radiation was used, graft versus host disease, a patient had prolonged graft versus host disease, there are all the risk factors that we talked about, then those cancers, like skin cancer, colorectal cancer, breast cancer, all those things are worth monitoring, maybe less on the breast cancer. So, I think with conventional reduced intensity conditioning, with no additional radiation exposure, no significant GVHD, I think the risk of subsequent cancers is probably very, very, very low. But again, there's issues like family history, like why did that person get MDS? So what are the risk factors for MDS? And could those risk factors for MDS also be risk factors for subsequent cancers? I don't know. I would need to get a bit more of a history on that person.
Dr. Armenian, you talked about allogeneic and autologous risk factors. Do any of these risk factors apply to CAR T transplant survivors?
We don't know. So because the reason why I say we don't know is because there's very few people who are walking around today who've only received CAR T and no transplant. So for many people, until recently, CAR T was a bridge to transplant. So it was really difficult to differentiate between CAR T-related exposures versus transplant. Now, there was a paper that recently came out that suggested that patients who receive CAR T therapy have a slightly higher risk of different cancers. People were specifically worried about like a T-cell lymphoma because, again, you have these activated T-cells that you have engineered, and the idea was that would they then take off and turn into lymphomas. We haven't seen that signal, but there is a broad concern that there may be higher risk of different cancers after CAR T. I personally think that it's incredibly difficult to untangle from the transplant itself. So, there's three things to keep in mind. One, as I said earlier, CAR T is rarely given without transplant, or until recently it wasn't. So it's hard, again, to untangle the two. Number two, we don't have a large body of data from long-term survivors of CAR T. We're talking about 5, 10, 15 years out for us to truly be able to understand the epidemiology of various cancers in this population. So it's going to take some time for us to be able to see that. And then three, the signal is there. We are investigating, but it's way, way too early for us to comment on any CAR T-associated cancers.
Can you comment on any advances domestically or internationally in the treatment of high-risk disease?
High risk, what kind of, I'm not really following.
Maybe it's high-risk factors or for new cancers, maybe. That's a shorter question.
What I would say is that, the transplant community, while it appears to be very big, it's actually not. The transplant scientists and investigators, especially those in the survivorship world, work very, very closely to develop guidelines, evidence-based guidelines, and these are international evidence-based guidelines that take into consideration the totality of available evidence, as well as integration of emerging data into our recommendations. So we're always doing tweaking and refining what we consider as high risk for developing a subsequent cancer. And what we have learned over the last 5 to 10 years has informed the new generation of guidelines that have come out in this past year, and will likely inform our work moving forward. So I would say collaboration is key to our success and to our recommendations.
How often do you recommend colonoscopies? This patient is 47 years old. They've only had one colonoscopy. They've had a transplant with TBI, and they also have gut GVHD.
This person's how old?
47.
Yeah, it depends on what their first colonoscopy showed. So if the first colonoscopy was completely clean, and again, this is not going on based on any guidelines whatsoever. Personally, I would not wait a full 10 years until doing the next colonoscopy. I definitely would like, probably do it more frequently, maybe every 5 years or so. Again, these are areas that are emerging as an area of study. We have to do cost effectiveness studies to look at different screening strategies, et cetera, for this population. But if I had got GVHD as well as TBI, I personally would not wait every 10 years. But that's, again, my own personal recommendation. It's not, it's not driven by hard data. And at the very least, we'd probably do it every 5 years or so.
How often should transplant survivors be tested for EBV?
I would only do it if there was a suspicion of, if there's lymph nodes that are enlarged or clinically. Lymphoproliferative disorders are relatively rare. They can happen after allogeneic transplant. As I said, it's due to prolonged immunosuppression after transplant that will put you at risk. But I don't think that there's currently recommendations for routine surveillance and screening with EBV. Typically, these lymphoproliferative disorders are relatively easy to treat. So, you should just have a low threshold. If you feel a lump or a bump, obviously report it to your primary care physician. And the further out you are from your transplant, further you are from your allogeneic transplant, the less likely that you will develop this lymphoproliferative disorders.
Can you recommend any checklists or care plans for long-term survivors of HCT with TBI, 15 years plus? She's saying her needs seem to be different from those in the first 5 to 10 years, but it's hard for her to find clear guidelines.
Yeah, I think, okay, let's start with just some of the general ones. I think for skin cancer, which for me is the biggest, to be honest with you, it's the most frequent cancer after allogeneic transplant, especially after TBI. So it's important that you have an annual dermatology visit to do a comprehensive head-to-toe evaluation looking for various skin cancers. It's also important for you to perform these exams more frequently yourself. So, at least, once a month. If not, if that's too much, then you can do it once every other month. But those are things that you should definitely be aware of. So that's checklist number one. And then everything else with the checklist depends on your own exposures. So depending on your age. So if you were young when you received total body radiation and you're currently still in your sort of early 40s, and I think you should have a very low threshold for skin cancers to monitor. And then, as I mentioned, it depends on what the exposures are. So, if graft versus host disease of the GI tract, you should be aware of colorectal cancer. And so those are sort of the big three as far as that you should be kind of really be worried about. Everything else could probably be picked up as part of routine annual evaluations with your primary care physician. So definitely having an annual physical with comprehensive, evaluation of both laboratory as well as physical examinations is probably the best thing you could do for yourself.
This patient was diagnosed with breast cancer 6 years after a bone marrow transplant for leukemia. Can the breast cancer treatment wake up the leukemia?
It's a very interesting question. No, it typically does not. But that said, the treatments associated with the breast cancer could put individuals at higher risk of developing leukemia and AML. So like Robin Roberts from Good Morning America had breast cancer and then eventually developed a type of a leukemia called AML. So we do see that. And so, I think you just have to have some conversations with your oncologist to, if you've already had the treatment, I wouldn't worry about your initial leukemia coming back. But within the first 5 years or so after your breast cancer treatment, you should have a low threshold for, you should have at least annual, CBCs done to check your blood counts, et cetera. And if your counts are, your platelets are dropping, hemoglobin is dropping, white counts dropping, then you should have a low threshold for additional workup from there. So.
Okay, this survivor is 63 years old and first diagnosed when they were 57. They had T-cell non-Hodgkin lymphoma unspecified. with one auto and one allo transplant. Do you know which type of cancer people have been known to get after having T-cell lymphoma?
Again, I mean, I think we're talking about, generally speaking, it really depends on what the initial exposures were for the management of the T-cell lymphoma that led to the allogeneic, the autologous, and then the allogeneic transplant. So, I mean, I think we'd have to know what those were. It depends if there was any radiation used for the treatment of that lymphoma. I think I was able to broadly articulate what the risk factors were. I think I worry about being able to make specific recommendations. So does a history of T-cell lymphoma put you at risk for a subsequent type of cancer? Not the T-cell lymphoma itself. I think the main issue is just the treatments that you received for it, as well as the additional exposures afterwards. So I think those will probably have to be personalized recommendations for follow-up based on what I've discussed today. So.
Are there any steps you can take to protect kidney function so you wouldn't possibly develop kidney disease after transplant?
I mean, I think making sure that you're well hydrated is really, really important. If you have hypertension, or if it's borderline hypertension, then make sure that blood pressure is well controlled, and ideally, if you can tolerate an ACE inhibitor, that way you can use an ACE inhibitor as a medication for both the management of the blood pressure as well as the kidney function. And so those are sort of the basic things that you could really do. Other than that, not too much. I mean, I think making sure that you're well hydrated, making sure that you're exercising regularly, you're doing regular checkups to monitor your creatinine, as well as I said, with anyone with a borderline hypertension, you want to make sure that that's under control, and with an ACE inhibitor ideally for some nephroprotection for the kidneys. And then if you have diabetes or elevated blood sugars, you want to make sure that that's well under control, because nothing injures the kidney more than chronically elevated blood sugars and diabetes itself. So you want to make sure that that's under control as well.
Okay, and this will have to be our last question. We are running out of time. How does having a cord blood donor increase the risk of myeloproliferative illness? How does having
I don't know if there's any. Yeah, I don't think that there's any data to suggest that cord blood transplant in and of itself puts you at higher risk of lymphoproliferative disorders. I know I put that in one of the slides. I think the issue is that many of the patients with cord blood have to have prolonged immunosuppression as part of the cord blood treatment, or the graft versus host disease that may develop afterwards. Or the one thing I'll just say is that just like T-cell depletion, the cord blood itself doesn't have a fully mature immune system just yet. So I think the idea there is that when you don't have a fully mature immune system, or an immune system that does not mature as quickly as, let's say, a non-cord blood transplant, then that will allow for the dormant EBV to emerge in the individual. So it's the same concept as you would get for T-cell depletion. Plus, in addition, any GVH, et cetera, that may develop afterwards. So those are sort of the emerging concepts around that. But cord transplants are not used as often, especially these days. So again, we'll have to follow the larger data as it moves forward.
Well, on behalf of BMT InfoNet and our partners, I'd like to thank Dr. Armenian for a very helpful presentation today, and thank you, the audience, for your excellent questions. Please contact BMT InfoNet if we can help you in any way, and enjoy the rest of the symposium.